till further notice.
Okay, good. All right. So today we're going to talk about the biomechanics of the tooth movement. It's how we move the teeth for braces. So it's very important to understand the foundation, how we move the teeth before you start any auto treatment for the patient. So as a learning outcome, is at the end of the lecture, you should be able to outline the different type of tooth movement and the type of forces used in orthodontic. So the desired tooth movement and ideal position of the tooth and jaw is brought about by different orthodontic and orthopedic appliances. So orthodontic appliances can be means of fixed or simple removable appliance. Orthopedic appliances can be headgear, face mask, and chin cups, and any other orthopedic appliance. But all these movements result from the application of the forces produced by the appliance. So whether they're fixed, removable, orthopedic, headgear, whatever, is applying the forces on the dental structures or skeletal, then creating the force. That's how we move the teeth and the skeletal around. But all these appliances are based on the same fundamental principle of engineering and mechanics. So forces applying on the soft tissue or the hard tissue, they cause changes, whether the movement or the jaw movement or the teeth movement. So biomechanics. So if you by definitions, biology is the study of life and living things. So whatever living things they consider biologies. Mechanics is a branch of engineering science that describes the effect of force on the form of motion of bodies. So if in a short form, these are orthodontic contacts. Just let me shut down this. So on a second. Okay, so in the short form, biomechanics is the reaction of the dental and facial structure to orthodontic forces. So like I said before, while you apply forces to the dental structure of the skeletal, they cause reactions. That's how we move the teeth and the jaw around. So what's the importance of studying this biomechanics? So you know what's the precise application of forces, then a better understanding of clinical and histology responses to the various magnitude of forces. So you apply light forces and heavy forces to cause a different response from the tissues. So that's how we want to improve the design of orthodontic appliance. So you see orthodontic appliance or braces, the design keep changing throughout the years. That's because there's a limitation what we understand how the teeth move and what's the force application to the tissues. So it's getting better and better, but until today, no one understands precisely how the teeth move. It's quite sad. So we're going to talk about mass, force, central mass, central cavity, moments, central rotation, and central resistance separately. But they all should be under the same topic, biomechanics. So what is force? Force can define as a physical quantity that act upon the body to change or tend to change the state of rest of the uniform motion of body. So there's a vector with the magnitude and direction. So force or forces, there are two components. One is the magnitude, then the other one is directions. So without either one, it's not considered force. Force is not only the quantity, must have a direction. So if you hear a Star Wars say, may the force be with you, it means there's a power and the direction to guide the force and magnitude. So if you see the picture on the left side, there's a force applied to the left, then you move the object to the right side. So there's changes of the rest of the uniform motions. Same for the tooth. If you apply the force from the front, then the teeth will go backward. That's how we do the braces movement. So braces movement generally divided into two types. One is the pull force, the other one is push force. So pull force means to pull everything towards you, then push force to push everything away from you. So on the first pictures, you can see the direction of pulling. So there's the initial directions, initial position, then there's a final position. Then push force, you push everything away from you, then there's the initial, then there's the final. So quite simple. So what's mass? Mass of any body is a quantity of metal it contains. So it's just the size of that object. Upper molar have more mass than the lower incisor. So the size of the molar is bigger than lower incisor. That's why the mass is higher for molar compared to the incisor. So central mass is each body has a point in its mass which behave as if the whole mass is concentrated at the single point. It's known as the central mass, which we call the central mass in a cavity-free mode environment. So central mass, it means that there's a free environment, no gravity, and there's a point which concentrated for all the mass in one point. We call it central mass. But this central mass, if in the environment which have a gravity, then we call it central gravity. It's the same point, but as it's in the environment with the gravity, then we consider central gravity. So central gravity means that each body has a point, which is the mass will behave if the whole mass is concentrated in a single point. It's known as the central mass, which we call the central gravity in the environment where the gravity is present. So without gravity, we call it central mass. With the gravity, we call it central gravity. So central gravity is the object balance point, the point where the whole body weight is concentrated. So it's summarized in these pictures. So if you put the pencil on the central gravity, then this pencil should be balanced. They're not falling to the left or right. So that point is called the central gravity. So same. All the objects have a central gravity. So if you put a pin or needles on the central gravity, then this object should be in the balanced positions. So it's the point through which the applied force must pass for a free object to move linearly without any rotations. So you put a force on this central gravity, and the object should move linearly without any rotations, left or right, up or down. So you put a force applied to the central gravity. This object should move in the same way as your force applied. So for example, if you apply the force on the central gravity, then to the right, then this object should move to the right. If you apply the force to central gravity, then to upward, then it should move the object to up, or the other way down, or left or right. So if you apply the force to the central gravity, they should move according to the force you apply. So a tool within a socket is invested in restraint by the horizontal support system. But for the tool, it's different because the tool is invested in the periodontal tissue, which is your periodontal ligament and the bone or the soft tissues, the gum. So it changed the central of gravity. So the tool is embedded partially in the bone, and the central of gravity shifted apically to the new position is called central resistance. So if they are not invested in the surrounding tissue, then there's a central of gravity. But if you invested in the periodontal tissue, then the central of gravity move apically to the new position, which is called central resistance. So that should be the original gravity, central gravity, without the surrounding structures. Can you see my mouse cursor?
Yeah, we can.
Okay. So that is central gravity without periodontal support. But when you have a bone or surrounding structures, then the central gravity move apically. They move a bit apically to the new position. We call it central resistance. So remember, this central resistance is when your central gravity change with the surrounding structures. So when we move the T around, then we are talking about central resistance rather than the central gravity. Because with these surrounding structures, the central gravity change to the new position also. We call it central resistance. So central resistance of the tool is the point on the tool or structures where a single force is passed through. It will bring about the translation or bodily movement along the line of action of forces. So this one is the same. Same with just now we're talking about central gravity. If your force pass through the central gravity, you should move the tool or the body in a linear position. Same for the central resistance. Central resistance just means the tool embedded or invested in the surrounding structures. So same thing, if you put a force through this central resistance, then the tool should move in the linear position or linear movement. So if you push the T to the right side or push the T backward, then through this central resistance, then the tool to move bodily or translation or linearly backward. So there's a central resistance. So a force passed through the central resistance of the tube will cause it to translate. Translate means they move linearly without causing any rotations. But if the force is applied above or below the central resistance, it causes tipping or rotation. So if you put a force through the central resistance, through central resistance, they should move the tube in the translation movement, means in bodily. But if you put the force above or below the central resistance, it causes rotation of the tube or tipping. So the factor which can affect or change the position of the central resistance are the root length and the overall bone support. So longer the root, the more apically the central resistance will be placed, and the alveolar bone is higher, then the central resistance will be placed more coronally. So to summarize in these pictures, so the longer root you have, then the central resistance is going to move downward or more apically. And the higher the alveolar bone you have, then it's going to move the central resistance a bit more coronally or a bit more closely. So if you apply these pictures to your periodontal support, so if you have less periodontal support or periodontal disease or periodontitis, then the bone resorb. So when the bone resorb, they're going to move the central resistance more apically. And same thing, if you have a baby tooth compared to the adult tooth, the adult tooth is longer, then the adult tooth, the central resistance is a bit more apically compared to the baby tooth, which is a bit more coronally. Do you understand this concept? Does it make sense?
Yes.
Yeah? Okay, all right. So movement is a bit different. It's tendency to rotate resulting from the force not acting through the central resistance is termed as a moment of force. So like I said before, if you apply the force above or below the central resistance, it causes tipping or rotation. That's what we call the moment. So moment in a short form, it means they have the force, magnitude of force, then they have a distance from the resistance, central resistance. So moment, it means the magnitude of force times the distance, perpendicular distance from the central resistance of the body to the line of action of force. So the S is a force and the dark arrow. So this side is a force, and there's a distance from the force directions or application point to the central resistance. This is called the distance. So the moment, it means the force, the magnitude of force times the distance. That's how we quantify the moment. So the unit usually is milligram, then times a millimeter. So because they apply the force for the orthodontic in milligram. So milligram is very small. We don't apply the force more than 150 milligrams. So it's very minimum forces. So the distance should be a millimeter. We don't apply the force more than 1 millimeter. A lot of time is less than 1.5 millimeters, 1.5 centimeters. Because the two lengths, then usually it's about, let's see how many meters. Yeah, less than 10. Yeah, usually it's by millimeters. So if you want to move the T in the bodily or translation movement, then you have to counterbalancing the movement for effective translation of body movement. So let's say you apply the force above the central resistance or below the central resistance, it causes the rotations. It causes the rotation of the tube. So in counterbalancing, you need another force, which is counterbalancing the rotation force in order to move the T bodily. So let's say you apply the force labially, you want to push the teeth backward. So you don't want to create this rotation. So you counterbalancing with another force, which is clockwise. If you apply the force from the labial side, you create the anti-clockwise rotation. So you need to counterbalancing with the clockwise rotations, which is going to use the bracket. The bracket, you put the rectangular wires in, then it creates a counterbalancing force. That's how we move the teeth, bodily or translation. So the central rotation is when the body rotates, there's another point located either internal or external to the body, around which the body turns. This point is termed as the central rotations. So central rotations are a bit different from the central resistance. There are two different points, but sometimes the central rotation can be same as the central of resistance. Depends on what kind of movement we're doing. But the definitions of this central rotation is mean when the body rotate or do rotate, then there's a point where they rotate around. That's called the central rotations. So central rotation is a variable point and change according to two movements. For example, for these pictures, it's causing the typic movement or rotation movement around the tips of the incisor. So this is central rotation. Or sometimes you use a higher force, the central rotation move more coronary, and there's become a central resistance or a central rotation at the same point. Then that's how we rotate the chair most of the time. So that's what we want, but that's what happens most of the time. So there are so many types of tube movement for braces. It is simply divided into seven types. So first one is tipping, which is a lot of time we do the removal appliance, and it causes tipping movement of the teeth. Bodily translations, and this one only can achieve by the fixed braces. Intrusion, extrusion can be either fixed or removable. Rotation, most of the time, fixed braces. Talking and uprighting, most of the time, is a fixed braces. So you can see removable appliance can do limited movement, whereas the fixed appliance can do most of the type of the movement for braces. So the first one is tipping. So simplest of all the teeth movement. So there's a greater movement of the crown than the root. So the crown will move more than the root. It's called tipping. So tipping movement are produced when a single force is applied against the crown of the teeth. So crown move in one direction and the root move in the opposite direction. So you can see from these pictures. So that's what we control tipping. So the crown tip backward. The central rotation is around the tips of the teeth. So uncontrolled tipping, it means the root will move forward and rather than staying in the same place. So controlled tipping, it means the crown moves in one direction, then there's a negligible or minimal movement of the root in the opposite direction. So central rotation will be in the root apex. I said before, if you want to tip the teeth back, you don't want the root to move in the opposite direction. So the central rotation should be at the tip of the root. That's how we tip the teeth back. But uncontrolled tipping, the crown moves in one direction and the root moves in the opposite direction to the last extent, which is unwarranted. So this is easier of all and desirable. Central rotation is closer to the central resistance. So sometimes the central rotation is coincide with the central resistance when we have this uncontrolled tipping, which is created by the high force. Bodily movement or translation. Translation of the two take place when the crown and the root of the two move in the same distance and in the same direction. So you can see the crown and the root, they move in the same direction and same distance. So the central rotation in infinity. So central rotation, there's no central rotation because they are moving in the same direction. So if you draw two parallel lines, then they shouldn't meet each other. So it becomes infinity. That's why we say the central rotation is infinity or doesn't exist if you do have bodily movement or translation. But believe me, in orthodontic movement, a lot of time we cannot achieve this bodily movement 100%. It never exists. More or less it causes some tipping or rotation. So intrusion, very simple. Intrude means to bring the teeth in to the gum or the periodontal support. So intrusion, if the body displacement of the tooth along the long axis in the apical direction. If the tooth move apically or into the bone or into the gum, we call it intrusion. So life force is required because the force is concentrated in the small area of the root apex. So imagine if you intrude the tooth, the force is concentrated on the apex. So this apex is very small area. So you should apply very gentle force to avoid the root resorption. So what happens if you apply too heavy force or high force, then it causes a lot of root resorption. So this apex will disappear. or it causes severe root resorption. The more force or higher force you apply, the more resorption it can cause. So you be very gentle for this intrusion. So extrusion is just the opposite. Extrusion is the body displacement of the tube along the long axis in the occlusal directions. So if you move the tube in the occlusal direction or bring it out from the gum or away from the periodontal support, called it extrusion. So extrusive movement ideally do not produce any area or compression with the PDL, periodontal ligament, but only tensions. So if you cause this or doing this intrusion, it causes pressure to the surrounding structures. But if you do extrusion, it causes tension. So this is compression or intrusion. It compress the surrounding structures. And this one is what we call the extension or tension, tension around the surrounding structures. So talking is opposite to the tipping. So remember the tipping. So tipping, it means move the crown more than the root. The crown will tip back, so the root will stay the same. So torque is opposite. The crown should stay the same, then the root is moving back and forth. So torque is achieved by keeping the crown of the tube stationary and applying the moment of force to move only the root. So root move, but the crown stay the same. But tipping is the opposite. The root should stay, then the crown should move. So it's the opposite, totally opposite of tipping. More root movement than the crown movement, lingual movement of the root. So most of the time you move the root backward and forward. That's what we call the top. Central rotation is inside the edge. So just now for tipping, the central rotation is the tip. Now talking, the central rotation is inside the tips, opposite. But the central resistance stay the same. Central resistance is the same. That's why the central resistance and the central rotation is two different things. You have to remember. But sometimes it can be coincide. Depends what kind of movement you're doing. Uprighting. Uprighting is a mesial-distal movement of the root. So during orthodontic treatment, the crown of teeth tips in the mesial-distal direction with the root tip in the opposite directions. So tipping of the root back to get a parallel orientation is termed as uprighting. So very simple. So let's say this root is tilted or crooked left and right. So you want to bring it back to the center. It's called uprighting. So either you tip the tip back to the distal or mesial direction. So to make the root parallel to each other, so some research say they're more stable compared to have a root which is not parallel to each other. So for orthodontic treatment, we're always trying to bring the root parallel to each other. That may be more stable. So rotation is very simple. You just rotate the tube around its long axis. So it's the labial lingual movement of the tube along its long axis. So two forces of equal magnitude acting opposite in direction produce a rotation, which is called the couple forces. So these two forces, since they are equal and opposite, cancel out any tendency of the body to move, but it produces the spinning of the object around the central resistance. So imagine there's a central resistance in the middle. So you apply the force in the opposite direction. You spin the tube or rotate the tube. That's what we call the pure rotation. But let's say if these two forces, only one exists or one disappear, then they are not only causing the rotation, but also causing the movement of the tube. If two forces equal, they cause a pure rotation. But if one forces exists only, then they'll cause more than rotation. They will cause a translation, tipping, or even root torque or whatever other movement, compared to have just double force, which is coupling force. So if you want to do pure rotation, the force must be equal on both sides. Then it causes a pure rotation. If only one force exists, then it causes more than rotation. So based on the duration application of orthodontic forces, then by the rate of the decay, the orthodontic force can be divided into three categories: continuous forces, then interrupted forces, and intermittent forces. So this one also very simple. It's all summarized in this graph. Order force duration that most effective move the T in continuous in lecture nature. So for braces, then a lot of time you try to move the T in the continuous forces because you want to be fast and effective. That's why you want the force all the time. But provided the force is really light and minimum. If you cause heavy force, first thing you cause underlying resorption, and second, it might cause a lot of resorption. The worst, it might cause devitalizations of the two. The two may become whiter. So for auto braces purpose, they always try to apply the light forces, but continuous. So it's an active organic force that decreases little in magnitude between the appointment period. So the force decay is only a fraction of the original between the visit to the clinician for the activation of the appliance. The force never declined to zero in between activations. So like continuous forces, then the cause of fundal resorption, which usually only can be done by fixed appliances. So if you wore braces before, personally, so you know every 4 to 6 weeks, we have to tighten the braces. So a lot of time, every time after tighten braces, then it'll be painful for 3 to 5 days. Then after that, settle down. Then we reactivate the braces the next month or the next 6 weeks. So in between the visit, the force will decrease or decay to a certain level. Then after reactivation, then it become heavy again. Then slowly it decay to a certain level. Then after reactivation again, then it go back to heavy. Then it slowly decay. That's how we do braces. Huh? That's why you need the constant adjustment or constant tightening of the braces. So a lot of time we put the flexible wire at the beginning, which is around nickel titanium. So nickel titanium is a flexible wire. So even though the force will decay, but they never go back to zero. It's still active, just that they're not that tight or not that heavy. But every time you reactivate or tightening the braces, then the force will go a bit higher. So the second type of force is interrupted force. The force level decline to zero between the activations. So just now, the first one never decreased to zero. Then the second type is zero. So since the force has dropped to zero at that point, it will remain in that position until the next activation. So the force will decrease to zero. If no activation, then nothing will happen. So for an appliance deliver interrupted force, the appliance component should have a high stiffness and initial activation should be twice the expected corresponding soft tissue deformations. So that's the typical activation for the removable appliance. So if you did the removable appliance before, in order to activate the component, we have to activate twice the distance you want to move the T. So let's say you want to move the T 2 millimeters, then you activate 4 millimeters. Then if you want to move the T in 1 millimeter, then you have to activate the component 2 millimeters. So this causes heavy force, but when the component becomes non-active, the force will decrease to zero. So heavy force, we know heavy force will cause undermined resorption, which is not what we want. So if possible, we want to have these frontal resorptions. So this can be done by fixed appliance or removable appliance, but most of the time removable appliance. Fixed appliance depends on what type of wire you're using. So the third and the final type of the force is called intermittent force. This force level decline abruptly to zero intermittently. So this is a bit different. This is quite special. The patient activates the appliance, not the doctor. Patient activates the appliance. So it causes heavy force. Again, it's undermining resorption. This usually is caused by this elastic or headgear. So if you attended the lecture before, then orthodontic, a lot of time we use a lot of elastic or be fixed appliance or headgear or chin cap or whatever component using this rubber band. So whenever the patient put a rubber band, then it creates a high force. So during the eating time, patient will take it off, then the force will drop to zero. Then after they eat or after their meal or whenever they're free, they put it back to rubber band. So it'll create a force again. So after a few hours, maybe they go, then they need to present lectures or whatever you want to talk a lot. Then they take out the rubber band, then the force drops to zero again. Then after they finish presentation or after they finish talking, then they put back the rubber band and the force will go back. So that's how we create the intermittent force. So the intermittent force usually caused by the elastic or rubber band or the headgear or chin cap or reverse pull headgear, which involve the rubber band a lot. So in summary, you see this continuous force usually only can be achieved by fixed appliance. Then intermittent force, interrupted force, usually by removable appliance. Then this intermittent force is by the elastic used for the fixed appliance or the headgear or chin cap or reverse pull headgear. So in summary, you see the force we use for different type of tooth movement, then it's always in milligram mg. It's quite light forces because you don't need a heavy force to move the teeth. So what happens if the heavy force applied on the tooth, it might cause the tooth not vital, especially if you knock on something. Let's say you knock on something, be it a hard object or someone punch you or you hit on the wall, then the tooth will become non-vital. So that's how the heavy force will cause damage to the teeth. So you see for all the tooth movement, intrusion use the lighter force, which is 10 to 20 milligram. Then the tipping, rotation, extrusion, all use about 35 to 60 milligram. So root uprighting, 50 to 100. And the most heavy force you use is about 70 to 120, which is bodily movement. That's why I say just now. We seldom use more than 100 milligram force to move the teeth. So with that, thank you. I think before we end these lectures, I think we go through some cases for braces. They understand how we move the teeth around. Can you see my screen?
Yeah.
Okay. So you see, okay, that's a typical case, crowding, severe crowding for braces. So a lot of time we take out 4 premolar, 2 top, 2 bottom. So you can see this 2 is jetting out, or the upper incisor foci. So we need a retrocline using the space created by the extractions. So for the incisor, that's a tipping movement. You can see on the second picture after completed, the teeth tip back. That's how we reduce the overjet. Okay, so you see for this lower incisor, retro-incisor, they're tilted distally, the crown. So in order to bring it back to the center, we have to upright it. See lower right 2 or lower lateral incisor, uprighted after braces. That's how we do braces. Again, this upper left canine, they're a bit higher or they have an open bite. So in order to bring it down, we use extrusion force. Extrusion force to bring it down so you can achieve the bite with the lower canine. So this is called intrusion. Intrusion. Again, for this, okay, for this central incisor, beside the tipping movement, we also use the intrusion force. You see, initially have a deep bite, and after that we have a shallow bite because we intrude the upper and lower incisor. So you see, for braces, all the movement that happens simultaneously. We seldom create only one movement for one single tooth. It can be multiple forces going on. So although we divided the forces into so many type of movement, we divided the movement in so many types, but usually they happen at the same time. Intrusion, tipping, extrusion, rotation, all happen at the same time. That's why the force created is not that simple. It's not only 10 to 20 millimeters or 20 milligrams, or not just purely 50 to 60 milligrams. A lot of time it's more than that because it creates one movement, not one movement. You're doing so many movements simultaneously. Okay, so for this one, same thing. You see the canine, we extrude the canine. And then this one, okay, incisor, same thing, we tip the back end by doing 4 extractions. You see, if you extract the two premolar, then you want to move the canine back. So this one considered bodily movement. You cannot just do simple tipping because you have to move the root back into the premolar space. So this one considered bodily movement. So only can be achieved by fixed braces. Fixed braces. So on the top left corner, this one might be rotation. So you can rotate it back by fixed braces. So same thing, this one open bite. So open bite, you want to bring the upper incisor downward, then lower incisor upward. This one, extrusion. Okay. Same thing, rotations, bodily movement after 4 extractions. See this one canine is so high up. You want to bring it down, extrusion. Okay. So this one, bodily movement after 4 extractions. Okay, 4 extractions. Okay. Okay, see well. Okay. So same thing. If you want to correct the center line, you have to move the two bodily. So you have to move the upper or the teeth to the left, then lower or the teeth to the right. That's how we correct the center line. Again, this one displacement or crowding. You want to move the teeth bodily. You cannot just move the crown forward. So you're going to leave the root behind. So you have to move everything bodily. Labially. This one also move it labially. This one is bodily movement. So bodily movement usually is the highest force you have to use. Okay, center line. Okay, for class 2, same thing. Increase overjet, point upper incisor. You want to tip it back. So you take out the premolar. That's how you're going to tip back the incisor using the space created by the extraction. So this one, we're going to tip back, retract the upper incisor. At the same time, we have to open the bite. So this one deep bite, we have to open the bite. So the lower incisor, we use a lot of intrusion force. The upper incisor, intrusion and tipping movement. Okay, this one open bite. We're going to extrude the upper incisor and lower incisor a little bit. Okay, functional. So you see functional. Functional is doing the same thing. It might tip the upper incisor back. So you can see the left and right. The X-ray show that the upper incisor tip backward. That's how the functional works. So same, same class 3. Okay. Okay, open bite, same principle. We're going to extrude the upper incisor, extrude the lower incisor. That's how we achieve the bite. Same thing, extrusion of the upper and lower incisor. That's how we achieve the positive overbite overjet. Okay. So impacted 2, after you open up the space, you're going to bring it up. So this one, extrusion. Same thing, this one, impacted, central incisor, you're going to extrude the incisor. Okay, uprighting. See, there's a impacted premolar. And you use the braces to upright it. Like say, you're trying to create a parallelism between the root, then the result will be more stable. So this one, I call it uprighting. You're tilting the two, mesial and distally. Same thing, molar. Molar, third molar, second molar, or whatever, incisor, premolar. You can upright it. Even though they're mesially impacted or horizontally impacted, you can upright. So upright, it means tilting the two, mesial and distally. So same thing, uprighting, 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 uprighting again. So gummy smile, same thing. For gummy smile, you want to intrude the incisor up. So you bring the incisor up, incisor intruded, then the gummy smile settle. That's how we settle the gummy smile. Gummy smile. Okay, you see how much intrusion will cause. You measure the distance between the base of the nose to the incisor edge, base of the nose to the incisor edge. Then you can see how much you intrude the incisor. Same thing, occlusal canting. You want to bring this up, Then you use the intrusion on the left side. Intrude. So the occlusal will be same level with the eye. So closing gap is using the bodily movement. For example, you take out this badly decayed second molar. You want to move this third molar forward. This one is a bodily movement. You cannot just tip the teeth forward. This one will not be parallel to each other. So for braces, we try to move the teeth bodily and make the root parallel to each other. Same thing, even you take out the first molar, you try to bring the second molar forward, then this root, you try to make it parallel, so it'll be more stable. Same thing, you try to move the two parallel or translation or linear movement, so the result will be more stable. Closing gap, same thing, you have to move the two bodily in order to achieve a stable result. Okay, this one tipping, tipping. Okay. Okay, just now we talked about the central resistance for the parallel disease patient. Then the central resistance will move more apically. So this kind of patient, you have to be careful because if you apply the heavy force, the two will rotate or the two will resorb. The root will resorb quite heavily. So this kind of patient, you have to be careful because the periodontal support is compromised. For this patient, you have to apply the force very gently, very gently. Remember, always light and continuous forces. So same thing, parallel support, because the periodontal support is compromised, so the central resistance move upward. So you have to be a bit careful. Okay, I think by that I already summarized all the movement for braces. Do you have any question to ask me? Any questions? Is everyone still here?
Yeah. For center of rotation, can you control like where's the center or?
Can you speak a bit louder? I can't hear you very well.
For the center of rotation,
yeah.
Are you able to control it or it's dependent on something else?
It means, can you fix the center rotation?
Like in one of your slides before the tooth movement, there are two types of like center of rotation. One is near the apex, one is the uncontrolled tipping, which is lower a little bit.
Okay. Good question. Let's go back. This one?
Yeah, like how do you control the center of rotation?
Okay. How do you control? You want the control tipping rather than uncontrolled tipping? Is that the question?
Yeah.
Okay. It's about applying the force you want. So you see, have you who have this lecture called Anchorage?
I don't think so.
Okay. So it's all about anchorage. If you want to move something to the left or right, you need something to hold it back. That's what we call anchorage or ankle. So in order to move the crown back, then you need to hold this tip in order to prevent it from moving. So you see this tip, in order to prevent it from coming forward, the key is light forces. Because if you use the heavy forces, then it will cause the root out of control. It might move labially. So if you want to control this movement tipping, then theoretically you should use the light forces. Then sometimes if you use the fixed braces, then you use a bracket to control it, the bracket. So I'm not sure you understand how the bracket works. So you see this bracket, there's a rectangular slot. Yeah?
Yeah.
So if you use a round wire, you put on a round wire, it doesn't engage on the bracket that well, compared if you use rectangular wires. So if you use a rectangular wire, you slot it in, then that will create a counterbalancing movement. of the force. That's why the control of the fixed braces is better than the removable. So this tipping, a lot of time, is caused by the removable appliance. So have you bent a labia bowl before?
Yes.
Okay. So you see labia bowl, the rest on the incisal on the labia surface. So if you activate using the loops, the labia bowl have the loops. If you crimp it or you activate the labia bowl too much, then there's a cause uncontrolled tipping. That's why the activation for the removable appliance is always twice the amount you need to. Let's say you want to bring the incisor back about 1 millimeter, then maybe activate the labia bowl about 2 millimeters, no more than that. Because if you activate more than that, then it cause the uncontrolled tipping. If you activate just slightly, about twice the movement you want, then it will cause this controlled tipping. So it's not all about the force you use. There's other factors involved also. The periodontal support, the tool length, and the force applied, and the type of braces or type of appliance you use can play a different role also. So, but for these pictures, the key is the force you apply. Does it answer your questions?
Yeah.
Okay. Any further questions? So I think for these lectures, you just have to know there's 7 types of tool movement: tipping, bodily, intrusion, extrusion, rotation, tucking, and uprighting. So in the exam, you mentioned all this. Then I explain what's tipping, what's bodily movement, what's intrusion, extrusion, rotation, tucking, uprighting. So the most difficult one is the tipping and the tucking. So a lot of people cannot understand these two. A lot of people confuse what is tipping, what is tucking. So tipping is a movement of the crown more than the root. Then tucking is the root more than the crown. It's opposite to each other. Just remember this. So intrusion, extrusion, again, is opposite to each other. This one is more apically. This one is more coronary. Bodily movement is everything move together. Crown and the root move the same direction. Rotation, move in the opposite direction. Opposite direction, coupling force. Then, uprighting is the root or the crown moving mesial or distally. So they make the root parallel to each other. It's called uprighting. Again, you have to know different type of tooth movement, different type of forces. You have to know it's a continuous forces, interrupted, or intermittent forces. Continuous forces usually is the right type wire used by the fixed braces. This one called continuous forces. They call it. You cause frontal resorptions. Then interrupted forces is heavy. Then they usually cause undermine resorption, and the intermittent force usually caused by the elastic or the headgear or the chin cap, whatever rubber band you use, then it causes intermittent forces. Interrupted heavy, but will stop and decrease or decay to zero in between the activation. So this one usually is by the removable. So it categorize continuous force by fixed, interrupted by removable, then intermittent by the rubber band, elastic. Then, if possible, you try to memorize these figures: tipping, bodily, uprighting, rotation, extrusion, intrusion. So usually I start with intrusion, use a lighter force, 10 to 20 milligram. Then you remember tipping, rotation, extrusion, this use a similar force, 35 to 60. Then followed by uprighting, about 50 to 100. Then the most heavy or higher force is used for is a bodily movement, 70 to 120. So this might come out in the exam. Do you have any questions? If no questions, I think just sign your attendance before you leave this class, and I'll see you soon when you come back. So the next lecture, I think, with me is about material. So yeah, we're going to talk about the dental material for braces the next lectures. Any questions? No?
No, doctor.
Okay, all right. Okay, with this, I thanks all, and I'll see you soon. Yeah.